shortly.
Right, thank you very much, Oyeyemi Ajayi, for the background report. And joining us right here in the studio is Dr. Adewale Samuel A. Premier, Senior Registrar, Community Medicine and Public Health, University of Abuja Teaching Hospital, Gwagwalada. He happens to also be the Assistant Secretary of the NMA here in the FCT. A pleasure to welcome you.
Thank you very much. Good morning, Nigeria.
And we have also been joined by Dr. Ekele Amadi Robert, Senior Registrar, Pulmonology, National Hospital, Abuja. Thank you for joining us.
Thank you so much for having me. Good morning, Nigeria. All right, you're welcome. Also joining us from our Jos studio is Dr. Kwashak Kevin, the President, Association of Resident Doctors, Jos, and a Senior Registrar, Urology, Global, and also a Global Health expert. Many thanks for joining us, Doctor. Next, we have Dr. Jakim Garros Susan sitting at the middle there. She's a Senior Registrar, Infectious Disease, also in the Jos University Teaching Hospital. Many thanks for joining us. And of course, also there, joining us for the conversation is Dr. Kefas Wyther James. He is the chairman of the National Association of Resident Doctors Medical Education Committee. Many thanks for joining us, doctors, right there in Jos.
All right. I guess we begin from here in the studio. Let me begin with Dr. Ekele by asking, what is it exactly about TB that even when there is cure available, it seems to still be a heavy burden in Nigeria?
Okay, thank you so much for your question. Okay, you know, disease tuberculosis, just like the background we gave earlier, you know, it's a disease that affects the lungs, you know, and it's not the treatment. You know, talking about the treatment, is not cured with just the usual antibiotics that Nigerians were used to. You know, we are used to just going over the pharmacy and taking maybe like medicines, very common antibiotics. But when it comes to TB, it's not cured with that. So the patients have to come to the hospital. You know, they have to get the drugs directly from the treatment center, what we call the DOT center.
Not off the shelf.
Yes, it's not off the shelf. So that's an issue. So you have to come to the hospital, and and the treatment takes at least 6 months.
Yeah.
You understand? So that's an issue. You know, it's not easy to swallow pills.
And every day, injections, every day.
Okay, although right now we're not really doing injections right now.
I know it used to be injections
yes,
every day for 6 months.
Yeah, for 6 months, and that's not easy. So that's one of the issues, I think, why tuberculosis is still a problem. You know, now even if it's treatable and curable, I think that's one of the reasons why it's a problem. So get the patients to come, to get tested.
Every day, which can be tough. Your job, your other activities, endeavors, it's understandable.
Yes, apart from that, you know, one of the main symptoms is cough. And it's not only tuberculosis that causes cough. So for them to have this cough, you know.
But the TB cough is persistent.
Yes, it's persistent. You know, so most times when they have the cough, they just think, maybe it's just one of those coughs.
Won't go off.
Yeah.
Regardless of the treatment, even if, so long as it's not the TB treatment, it will stay.
Yes, it will.
All right. Thank you so much, Dr. Amadi Robert. Let's get to Dr. Adewale Samuel Adeleye Premier now. You heard Dr. Ekele talking about why we still have TB with us. Not just that we have TB with us. Statistics states that Nigeria is ranked the 6th nation with the highest number of TB cases globally. And looking at what the WHO puts out there, the incidences of TB has increased from 2020 till date, rather from 2000 till date. And to put a figure to that, the report says that as at 2000, we had about 269,000 cases. As at 2022, it rose to 479,000 cases. outside some of the reasons that she has mentioned, what really, you know, are the causes of this, and why is the number increasing, you know, despite the fact that it is curable?
All right, thank you very much for that question. Like he has rightly mentioned, first of all, we need to know the TB we're talking about is disease of the poor, you know. So because they call it disease of the poor, overcrowding, most of the people that comes down with TB, they are the one staying at the, you know, those areas that are not, that are hard to reach, let me put it that way, slumped and all of those ones. So because Nigeria has been doing well, look, before now, pre-COVID era, if you look at the incident, there was a slight drop in incident. But after the COVID, because due to lack of access to health care delivery and all of those ones, from that 2002, we had a surge in the incidence of TB. So, and then partly again, what could have been responsible for the increment in this, because you know, when you have cough, like I said, a lot of people say, no, this is like the cough of this, the cough of that. They take anti-tussies, like the cough syrup and all of those ones, because most of them, again, they look at it that me having TB, there is a bit of, you know, stigma attached to that. So even when you tell them, even the people that come to the hospital, you have cough, they say, please, madam, you need to do TB test. They will like, what's going on? Because it sounds big. Yes. So actually, I think from the Ministry of Health, National TB, Leprosy and Borreliosis Control, actually they've been doing a lot to look at the community awareness and all of those ones. Now we even engage a lot of CBO, community-based organization, because the awareness at the grassroots level is very, very important. Because we know the awareness, they've been doing a lot. Because if you look at the strategy of NTB, at least as of 2020, Nigeria was at least Africa and Europe. Nigeria, one of the African countries that actually beat the target for 2020. So we're still looking at 2025, 2030, 2035.
So are there different types of tuberculosis? So, you know, what type are we prone to in the country?
Well, there are majorly two types of TB, you know, considering the area of the body they affect. Like we've said, primarily and majorly, they affect the lungs. That is the pulmonary TB. But any other form of TB that affects any other part of the body apart from the lungs, we call them extrapulmonary TB. It can be TB of the stomach, TB of the spine, then TB of the brain and all of. So it's a multisystemic infection that can affect any part of the body. But primarily, we group them into two: pulmonary that affects the lung and the extrapulmonary. Majorly, the one we're battling with in Nigeria is pulmonary TB. But not to say we don't have, you know, the incident of extrapulmonary TB. So, yes.
All right, thank you very much, Dr. Adewale. Let's now head over to Jos, where we have three doctors seated. Let's begin in Jos with Dr. Jakim Garros-Susan, who is Senior Registrar, Infectious Disease, JUTH, that's Jos University Teaching Hospital. And let me ask, in spite of TB being, you know, treatment of TB is available in Nigeria, and as far as I can remember, it is free. Why is it still considered a neglected tropical disease?
The question, TB is a communicable disease, as we are all aware of, and is still of public health importance. And despite the several awareness that has been going on, one, a lot of people, once they have cough, they think of other things before thinking of tuberculosis, because tuberculosis is associated with stigmatization, of which they do not want to be associated with. And despite the fact that the drugs are free and also the investigations are free, people find it difficult to come to the hospital to, before you see, they have a problem of seeing the doctors, the timing of seeing the doctors, the duration of stay of seeing the doctors, and also some people have phobia for coming to the hospital. And also some people have phobia for taking medications. So despite the fact that there is awareness and the drugs are free, also the drugs are at least good and reliable for people and cure TB, people still find it difficult to come to the hospital and then get treated. Another thing is we really need to do more work with our education, patient education. Because first of all, once you have symptoms of cough, which is symptoms of TB, which is cough, they think of other things first. Oh, is this a pneumonia? Is this COVID? Or is this just a common cold? Should I just run to my over-the-counter drugs and take my medications before coming to the hospital? So these are issues that we are trying to sort out by educating people that TB is a disease of public health importance and it's communicable. So the earlier you present yourself to the hospital, the earlier you get treated, the earlier you start your medications, the better for you, the better for your family, and for the betterment of Nigeria.
Dr. Susan, you have said that TB is free. Treatment of TB is free. I would like to find out if that is true. I'd like to Dr. Kevin to respond to my question now. How true is it that the treatment of tuberculosis in the country is free? Is it completely free? Because I saw a report some days ago that says that that for every patient that has TB in the country, they spend over 20% of their income taking care of the disease. Please, could you, speak to us, to the extent to which, the treatment is free?
Okay, thank you so much for that. Yes, I agree with her. Generally, the treatment of tuberculosis is entirely free as far as Nigeria is concerned, and some of the tuberculosis endemic regions. You see, when you come to the hospital, usually before the doctor even gets to that point of making that diagnosis of tuberculosis, a lot of things could have been done. Probably some other investigations. You have to pay for it from your own pocket in case you are not covered by national health insurance. So you have to spend that until the point at which the physician has made that diagnosis of tuberculosis. But even at that, there are some investigations for the tuberculosis. Once the physician has his suspicions for that disease, it is paid by some organizations or by the government, so to say, in terms of collaboration. There are some investigations when we write, we tell the patient, these ones are free. Just go to the lab, they will do it for you at no cost. So, and then once the diagnosis has been made, all the medications are free. To the best of my knowledge, nobody have ever received any money in exchange for medications for tuberculosis. But when you're talking about healthcare generally, accessing health services, it does not just involve medications. Okay? There's what we call the direct and indirect costs of healthcare. How much does the patient spend? For instance, if the patient is coming from 20 kilometers away from the hospital, or 5 kilometers away, how much does the patient pay as his transportation before coming to the hospital? You're also looking at if this patient have already stayed out of his work to just to come and access this care. These are all some of the costs we're talking about. Then when they come, they have to open folder in the hospital. They need to open a file before they see a doctor, before a doctor sees them. Sometimes, like my other colleague have mentioned there, they have cough. And those coughs are usually related to probably chest infections, some other chest infections. So they will go to some private settings, they will spend money for that and all that. And before you get to know, this patient could have spent a reasonable amount of money. But I can tell you that treatment for tuberculosis is entirely free.
Lack of awareness is what is responsible for the number of deaths that we're experiencing, because the statistics says that one Nigerian dies from tuberculosis every 5 minutes, and Nigeria accounts for 23% of the death burden in Africa. So could you speak to us about that? Is it that access to this free care is a problem in the country, or is it just the awareness that we already mentioned? What really are the factors responsible for this high number of deaths?
It's a multifactorial issue here. You know, the fact that Nigeria is still battling with tuberculosis is a multifactorial problem. Number one, yes, issue of access to health services is one of the issues that we cannot run away from. We have a very weak health system in Nigeria. You know, if you have a patient who stays, for instance, in let's say in Kefi, and then the patient has to travel down to maybe a village in Kefi, and then the patient has to travel maybe about 10 kilometers just to access care for tuberculosis, and the patient does not even have money to eat for that day, not to even talk of transporting himself. Of course, the patient will not go there to access the health care. But how this health system, if health systems are strengthened, what I mean by this is that by the time you have like primary health care systems that are well strengthened and patients can easily go in there, probably just a few minutes walk from your house to that place, you have all the care you need as per tuberculosis, then you know, of course, that would actually solve the problem. So access to free care is another problem, which the government needs to look into it in terms of strengthening the health system, right from the primary health care system to tertiary system, and then to secondary healthcare facilities, and then down to the tertiary. You know, ideally in the tertiary health system, people should not be seeing common tuberculosis. Okay, these things should have been addressed at basically the primary and secondary. If it becomes complicated, yes, you can now send them to the tertiary where specialists will be able to see them. Another thing is the emergence of the drug resistance. Okay, we're beginning to experience resistance of drugs of this tuberculosis. And you know, once you start taking medications for tuberculosis, it's usually classified into two phases, the intensive and then the continuation phase. The physicians always counsel these patients on the need for compliance. If you miss this medication for a certain period of time, it will amount to going back to start taking all over again. And taking these drugs on its own is not easy. It's a very difficult task. That's just the truth. And if they don't do that, probably somebody goes back to the village, nobody to monitor him to say, oh, this is your time to take medications and stuff like that. Then that patient is already creating room for drug-resistant tuberculosis. So that, again, is actually increasing some of the burden of tuberculosis we have in the country. Again, you know, just before 2020, just like my colleague have mentioned in the studio there, Nigeria have tried as much as it could to address this tuberculosis to a greater extent. But prior to that COVID-19 epidemic, you know, the COVID-19 came with its own unique issues. And the interruption of health services at the time also contributed to the increasing incidence of tuberculosis that we're beginning to see in the environment. Not to also forget about the climate change. I think it's another factor too, you know, that is actually affecting tuberculosis treatment and then also increasing the incidence of tuberculosis in our environment. But I think, be that as it may, Nigeria as a whole, I think we're making some progress. We should not just be talking about we're not doing anything. I think we're making some progress. When you look at the CDC statistics currently, Nigeria is somewhere at the fifth. There is what they call tuberculosis belts or tuberculosis regions. You know, India is topping the list. Then you have Indonesia and others before even Nigeria. Nigeria is somewhere around the fifth. It put at about 4.7% compared to India that is around 27%. So you can see we're making progress. So if only government can actually address some of those issues that I've mentioned earlier, then I think we'll be able to work towards eradicating, towards having a zero tuberculosis in Nigeria by the year 2030.
Thank you very much, Dr. Kevin. Since we have talked about awareness, talking about creating awareness, how people can get treatment, to what extent the treatment is available and all the likes, let me head to Dr. Cephas James, who is also there in Jos. You are chair of the NAD Medical Education Committee. So tell us, the issue of awareness is quite serious, and we know this for sure, especially in the rural areas. Most Nigerians in these parts still believe that TB is contracted through the most ridiculous of means. What are you doing to address this kind of mentality?
Thank you very much. The issue of awareness for TB is as serious as the disease itself. And that is why we at the Nigerian Association of Resident Doctors level, we are making our own part in curbing this TB by programs like this. And sincerely, it's pathetic when you see a patient having to go through a lot. And some of this silent knowledge that is able to help him in prevention and it even spread to his immediate family members is even not there. You realize that a lot of money goes into treatment, but we neglect the aspect of public health, the public health perspective, which is the area of awareness, which is in the area of disseminating information about TB, which is even in the area of stopping the spread. So you realize that a lot of population of Nigeria lie within the rural setting, and you discover that these people don't even have access to electricity. They don't even have access to the internet. So how then can you go, can you make these people know about TB? And that is why we are here in the studio to discuss TB and to make them who have access to NTA, because NTA is found in almost all local government and have access to a lot of people. And Nigeria Association of Resident Doctors is doing that aspect of public awareness part to be able to help those that are within the rural setting and even those within the urban setting. The World TB Day is a commemoration to spread this knowledge. It's not enough for people to say, oh, we are working hard to making sure that we treat the condition. But what are we still doing in order to contain its spread, as well as allow people have access to information for those undergoing medications, the nutrition they need to take, and all that. So, but another thing we also have to understand about people's perspective of TB is that a lot of manpower challenge is also there. As my colleague was saying, these cases are cases that should be handled at the level of the primary health care or the secondary health care. But how many TB specialists do we have in those hospitals? How many TB specialists do we even have in the secondary health system? A lot of these have to come together, and then the synergy about working as well as having the load of patients, having to travel kilometers to access this care, because this is also very important. Well, if somebody will have to travel kilometers to even have a diagnosis of TB, then you can see the amount of trouble we have. And when all of this congests in the tertiary health system, you realize that within the tertiary health system, there is in itself a whole lot of manpower challenge. Doctors are being overworked. A lot of these patients come and you see them queue up. You have them in hundreds to be seen by just a doctor. So you realize that the problem is actually multifactorial. And we feel that if government can come in strengthening training even for doctors, a lot of doctors have interest in the treatment of tuberculosis, but are not trained with regards to the modern technology that is involved in the treatment of people. Countries have gone, the countries that are able to eradicate these conditions have invested heavily in manpower development within the health system. And that is why it is very important for government to also realize that awareness for this condition is something that all hands have to become on deck to making sure that we have a successful rate of eradication of tuberculosis. Thank you.
Thanks, Dr. James, for your response to that question. Indeed, when you spoke, you made a reference to a point, I had on my mind when Dr. Adeleye was talking about lack of awareness as being one of the major causes responsible for, the statistics we have, as regards tuberculosis. You heard Dr. James talk about an unhealthy health system in the country has been a factor, because we also know that so many cases of tuberculosis are undetected, and that is one of the major reasons why a lot of people still die from it. In fact, it states that 23% of childhood tuberculosis cases are detected, while the remaining 77%, we're just talking about children now, go undetected in this country. And of course, consequently, when it's not detected, treatment is lacking, and then the end cause is death. So how would you want to respond to, some of the points raised by Dr. James, talking about the unhealthy health system, in taking care of some of these diseases that are preventable and curable?
Right, thank you very much for that. In as much as I'm aware, it's not totally the way people actually visualize it, because I'm part of the TB management in the teaching hospital. So, and then the National TB, Buruli, ulcer and leprosy control program, actually they are doing a lot, because at that level, at the national level, they have some working committee or working group, and then at the state level where they have some coordinator, and then at the local government level, across all the 774 local governments, we have those that we call the TBLS at the local government. That is TB and leprosy control, leprosy supervisors. So all of these supervisors too, they have their own assistants that look at, the control of TB at the local government level. Like I mentioned earlier, that now the National TB, Borreliosa, and TB, leprosy and Borreliosa control program under the Federal Ministry of Health, they're actually doing a lot. Now they are engaging a lot of community-based organizations, in which they are even paying some of them for contact tracing, ensure that the patient comes for their medication, the awareness at the community level. Last year, there was a program launched, they call it PQE program. That is the Program Quality Improvement and Efficiency, where they even employ some people that are not within the hospital setting. They call them linkage coordinators. So we have hours in Gwagwalada in the teaching hospital. So this linkage coordinator, the hallmark of this PQE program is to ensure that every patient that enters into the hospital at the OPD, that is outpatient department, are tested for TB. Since the TB gene expert is free of charge. So this linkage coordinator, they are the one that, mobilize at, every OPD and ensures that, you get there.
Are you sure that is available in all the health institutions we have across the country?
I can't say. I can really talk about within the purview of where I work, because I know I'm part of it, and we have, even in FCT, so because we have our quarterly meeting and all of those, for the FCT, I can say we have this on ground. So these people, they are the ones that, interact with the patient, get the sputum sample, takes to the lab. Within 24 hours, the gene expert result is out if there is no problem. So come to TB. And those that, all of the patients, you get this thing from the sputum, you register them in a presumptive register. So once the result is out, if it's positive, you register them in the positive or case register. So, and with this, I think there has been some, level of improvement, because I know I work closely with my TBLS at the local government level and the assistant for Gwagwalada. So, especially for the drug-susceptible TB, and more on the drug-resistant TB, because Gwagwalada is now one of the centers that treats drug-resistant TB. Unlike before that, you have to send to Kaduna or I know Gwagwalada could because I am the focal person or OPD doctor in the UATH, where Kuje, Kwali, Abaji, Gwagwalada, they are under my own center for the treatment of drug-resistant TB, and I work closely with this linkage coordinator and the local government supervisors.
Okay, I now see, what they say about the cost of treating TB, because when you mention places like Gwagwalada, Abaji, these are extreme places, and imagine somebody going to those places from one extreme. You don't have to relocate to be able to access treatment for TB. But again, Dr. Kefas spoke of, lack of specific training for people who are interested in treating TB. And I ask, this is an area you should be very much familiar with, Dr. Ekele. What does it take to equip medical personnel, or perhaps anybody for that matter, to be able to treat tuberculosis?
Okay, thank you so much for the question. Okay, so what is it to train to get personnel who are interested in
yes, to train people to be able to treat specifically tuberculosis.
Okay, so what it entails will be to train them about the disease, teach them about the disease, the presentations, the treatments and the complications, that could arise from it. Also train them about the testing, because there's a special, just like you mentioned, the gene expert machine, that's what's mainly used now for the testing. Apart from other ones, there's this sputum AFU, where you do microscopy, and then there is culture, which is not available everywhere. Like for us, we send our patients to Bingham University, and also to them in Guadalajara. So you can, just like you said, imagine the distance they have to move. So just like Dr. Kefa said, if they can bring this more to the grassroots, like he works at the teaching hospital, which is very far. So if they can have this personnel train
like
them.
how much, when you say more to the grassroots,
like the primary care, in fact, not even the secondary, to the primary care level, to the health centers, that are closer to the people. Just like I said, most of the patients are actually poor people who stay in crowded places, because for you to contract the disease, you have to be in close contact with someone who has the disease for at least 8 hours in an enclosed place, So imagine all the places where they live in crowded places, people who live under the bridge, who stay in crowded places. There are people who are mostly affected. So if you can get people, train them about the disease, the medications, how to administer the medications, and then the testing, and then get them to work at the primary care, I think that will really go a long way to help. So like we have bodies, just like you mentioned, the National TB, Leprosy and Broly, and other NGOs like KNCF, there's only, all these bodies, they are partners, and it will be good if we have more, non-governmental organizations like that willing to help to bring the care more to the primary health centers. Not then for us in the tertiary, at the tertiary level, we will see only those with complications, but the treatment will be more effective if we have the trained personnel more at the primary care level, because that's where you have more of the patients, so that this issue of them getting to transport themselves
accessibility,
accessibility,
so
would really be taken care of.
And of course, that's the first contact for most people whenever they are ill or they have
because they now have to be
with their
referred
health.
to other places where these things can be taken care of.
All right, thank you, Dr. Ikele. I'd like to get to Dr. Kevin again. We're talking about tuberculosis, and this is really very sad. And then, like Dr. Adelaya said earlier, it's a disease of the poor. Would you say that is why less attention is being paid, to this particular disease? Because from the statistics, it shows that tuberculosis is killing more people than COVID did. But we saw the attention that COVID got, all right? And TB keeps killing people every day. And like I already mentioned, every 5 minutes, someone dies from it. So far, from what we have said, most of the treatment that is available in the country are coming from international donors. What can government do, really? Because I think that if there's a huge collaboration between government and international donors that we're seeing at the moment, maybe we'll go some far. Dr. Kevin, what's your view?
Okay, thank you for that again. Well, you see, I agree with you that tuberculosis seems to select some few group of individuals. Unlike COVID, that's virtually, the attention COVID got, because COVID was practically affecting everyone, regardless of your socioeconomic status. On the other hand, tuberculosis, well, most people will argue that it's actually disease of the poor. Probably, if you look at the possible predisposing factors or the risk factors that eventually leads to tuberculosis, such as poverty, overcrowding. It's usually the poor that don't even have a good housing to stay in. So you see a house where it's just a room of probably 1 or 2 persons, and of course you're having up to 10 people sleeping in that room with probably 1 window or at best 2. That's a poor ventilation. So that alone has already predisposed to a lot of poor people to having tuberculosis. So these days, like in Jos, for instance, now, if you come to Jos, you go to Bokos. I'm sure you're aware of what has been happening in Bokos and Barikin Ladi recently. Some of the IDPs have well over 14,000 individuals camping in that place. So that's a recipe already for a disaster to happen. Because if one person contracts tuberculosis there, virtually everybody will go down with tuberculosis. Because there you have children, you have women, pregnant women, and then the aged. And these are people who practically get predisposed to this infection. So, of course, the fact that you're poor, it does not mean that the government should not pay attention to you. I'm not sure being poor is a choice. Okay? Being poor is not a choice. If everybody have his own way, everybody wants to be rich. But I think nature has made it such a way that probably the society has to be stratified. And for those who are already, unfortunately, to be in that cadre, I think the government needs to do more. The government needs to take this disease very, very serious. You know, sometimes when you meet government officials and you talk about tuberculosis, they will say, what are you talking about? Tuberculosis they've been hearing for a long time. But let me just contextualize this. You see, globally, about 2 billion people are infected with tuberculosis annually. 2 billion. If you look at 2 billion, it's quite a huge number. That's like 1/4 of the total population in the world. And out of these 2 billion, you have like well over 10.6 million of them that become ill. You know, not everybody that has tuberculosis that actually becomes ill immediately. Some people carry tuberculosis for a while and they will keep spreading it. You know, you have over 10.6 million of them. But to make it even more, comprehensible, we have about 3,500 people that die from tuberculosis every day. Every day. As I speak to you today, probably the world will record about 3,500 people that will die from tuberculosis. Probably at this very second that we're talking, somebody is already dying, or somebody has already died from tuberculosis. And let's not forget that Nigeria is one of the countries that is really suffering from this disease. So we need to understand how important for this tuberculosis needs to end in our own country. Like I said, poverty is not a choice. So I would advise that the government needs to actually put in a lot of resources in strengthening our health system. We've talked about the primary health care system. We've talked about the secondary health care system. In fact, we can even go as low as having people, such as some of these auxiliary health workers, who are trained in less than 18 months in some institutions, and they go inside the community, into the communities, not even waiting for people to come over to the hospital. You know, looking at some of these people who are actually affected and give them the necessary care they need. And if there is need, then they now refer them to a better facility. Other than strengthening the health system, I think our issue of vaccination needs to be taken up a bit more serious. You know, we know that tuberculosis is one of the vaccines that are given, or immunizations that are given within the first 24 hours after birth. But I think we've become so comfortable believing that every child that is born usually gets this vaccine. But I think, in my opinion, this is a wrong assumption. It's truly a wrong assumption. Yes, for people who give birth in hospitals, they get this vaccine. What about thousands of people or millions of people in the rural communities that give birth at home? What happens to them? What are we doing about that? So you see, it takes me back to the issue of having some people even going into the community, giving some of these vaccines to women who give birth to children at home to ensure that these children are well vaccinated, because, in fact, that's the primary point of prevention. Okay? And the SDG, if you look at the SDG from the global health perspective now, the SDG 3 is talking about health and well-being of everyone. But in ending tuberculosis, when government wants to be serious about ending tuberculosis, it does not just look at the health system. There must be multi-sectoral collaboration. There is. If you look at some of the SDGs that talk about housing, you know, having good communities, it talks about water and sanitation. All these are some of the ministries we can bring on board. And then these people need to actually come up and then say, okay, let's collaborate. If we do this, what do we do? Can we provide good housing for people? If we provide good housing, it means that we're already winning the war. If we give people good water and sanitation, we're already winning the war. If we actually act well on the climate change, we're already winning the war. So it has to do with multi-sectoral collaboration. Importantly, the government have to invest on research. I think in Nigeria, it's one of the things we've actually neglected over time. Okay? Public health, global health physicians, pulmonologists, infectious experts have to come. They have to come together. And government needs to support them with good amount of money for research so that they understand what works for us in our environment in terms of giving these medications, and not just about giving the medications, in terms of purchasing the drugs. I agree with you. Most of the funding comes from donors, like Global Fund. Assuming something happens today and Global Fund falls out, what happens to our people? So government it's high time for us to take over. It's high time for us to take over. I'm glad the current Minister of Health is an expert in infectious disease. So as we're talking, I'm sure if he has the opportunity of listening to this, he will understand exactly what I'm talking about, and then there is need for him to actually be a bit more proactive in ending this disease, because tuberculosis to one person is tuberculosis to all. You know, it's the whole community that is at risk. You can get it from church, you can get it at school, at work, even at the studio. But before I end, let me say something about the role of media in terms of ending this. It's not just about the government. I think you as media practitioners also have a role to play. You know, when I was growing, I remember on NTA, there was a time when you see pictures of individuals coughing. They have white handkerchief, they'll cough and you see blood, you know. It's just like a short script, so to say. And that sends strong signals, even to people in the community. You know, I remember even people, mothers and grandmothers in the village who practically don't understand what we're talking about now because English is not their first language. But they will really relate with what you're doing. So they see somebody coughing, they say, oh, if you have this symptom, I think you should go to the hospital. If you're losing weight, you should go to the hospital. You know, this alone is even much important than even what we've been talking about, because they are the vulnerable groups. So where is the role of the media currently? Where has those programs gone to so far? You know, NTA used to do it. NTA have stopped doing it. What about the other radio stations? I remember then they will see somebody coughing even on radio. You are in the remote setting, you don't have light to watch television, but you could hear over the radio that people are saying, oh, if you have this, go to the hospital and do this and do that. So I think we should not just be talking about government. Yes, we're calling on government to invest, call for collaboration, but in this collaboration, I think media too has a great role to play in ending tuberculosis by the year 2030. Thank you.
Respond to the finger he's pointing at the NGA. You know,
this is part of what we're doing.
Exactly.
I'm sure.
Talking about TB now,
and
and rest assured that if we have jingles, you know, talking about this, I'm sure that the management would gladly aid.
You can provide and
you know,
approach. You approach media agencies. I believe so. If you approach media organizations, not just NTA, I believe that they will be more than willing, you know, to welcome you with open arms. But that said. Data from the WHO, for instance, suggests that about 40% of the TB cases in Nigeria are not reported. You know, and such persons do not seek medical care either. So how do we begin to mop up, you know, this number to reduce transmission? Let me ask Dr. Susan there in Jos.
Thank you so much for your question. Yes, we know that not entirely everybody knows the symptoms of tuberculosis, and most of the time they are wrongly diagnosed. So, and then with the fact that people don't really have money to come over to the hospital, and they are being seen by some that really don't know the symptoms, sign, investigations of tuberculosis, so they end up dying at home. And if death occurs at home, we don't get the statistics to even report it to the state epidemiological unit, right? So what usually we advocate is that we advocate for patient education. Just as Dr. Kwashak has said, that this should be done down to the level of the local government areas, to the villages, using the state government, the federal government, the media, and also getting other people that can go down to those local governments to advocate for to tell people what TB is, to tell people the symptoms of tuberculosis, and to educate people how it's being diagnosed, and to also encourage people that this is free. So when we get such people coming over to the primary health care centers, coming over to the secondary health care center, and also coming to the secondary, that's the tertiary also, we can be able to have a number of people with this disease and also treat them and have statistics of how many people die. Because, of course, really, we can only get statistics of people that present to the hospital. We can't get statistics of people that die outside the hospital. So the best thing that we can do now to avoid that is patients education, and also advocacy, so that more people visit the hospital. We make the visitation, the timing of visitation, we reduce it, and then also we make hospital accessible to those people. And then patient education on the signs and symptoms of this disease can also help one that is in the village, will help people around you. So it's not just you having the disease. If your neighbors knows the signs and symptoms of tuberculosis, they can help you. Also bring you to the hospital. Once they suspect, they can tell you to go to the hospital, right? Instead of staying at home and then getting complications and dying. So it's patient education is very, very important, because if we educate patients, educate relatives, educate people that don't know anything about tuberculosis, then we have gone 100 miles by saving people from dying from this disease and also getting the right statistics. Also, there's a place for research, right? Where you don't just stay in the hospital and wait for people to come to you. You can also as well go to the communities where they are predisposed or at risk of having this disease. So once you go on for research, in the process of research, you also educate these people on the signs and the symptoms. You also search for people that have these symptoms, and then you are able to isolate them from other people that don't have the disease, and you are able to get the statistics required of how many people have the disease, how many people have died from the disease, and you are able as well to do contact tracing. So research also has a great role to play. Thank you.
So I'll just move to Dr. James now. We've talked about, lack of awareness. We've talked about the health system being unhealthy and all of that. But let's talk about the treatment of TB itself. Tuberculosis, even when you're diagnosed and, you're placed on treatment, it's a very difficult illness to treat. I use the word difficult because from what the doctor mentioned here, okay, initially it used to be injections, now it's a drug, and the tablet is really quite big. And I hear that a patient suffering from tuberculosis has to go to the hospital every day to get to access that drug, right? I don't know. Could you speak to us about the treatment itself? Because we talked about the drug-resistant tuberculosis. That's because even when people are placed on it, they're not consistent. They're not able to keep up with the whole process. It's for a 6-month period. I mean, is there a way, this could be much easier and better? Just speak to us about the treatment, really.
Thank you very much. So the treatment of tuberculosis is difficult, as you said. It's quite difficult. Not because patients come to the hospital every day to get these drugs, but that you would have to be subjected to one thing every day is so tiring. Psychologically, when you see patients, we try to put ourselves in the shoes of these patients, because someone was telling me that he is tired of taking drugs every day. And I gave him an analogy. I said, can we now say that because we ate food yesterday, we shouldn't eat food today? Or that we ate in the morning, we shouldn't eat in the afternoon? And he saw a lot of sense in what I was saying. Because for him, he is looking at food he's looking at his medication as something cumbersome. So, the management of patient is always multifactorial and multimodal. There's a lot that is involved in the treatment of TB. For the single fact that you are taking a drug that is metabolized by your kidneys and by your liver means that those structures in your body that metabolize those drugs need to be monitored. It's not just enough for you to be heaping this drug to solve your TB problem, but that other systems in your body have to be checked to know how the drug is interacting with them and how they are able to be safe while undergoing that treatment. So these are all factors that come together in the treatment of TB. Nutrition is another. You're taking drugs that have a lot of activity on your lungs or whatsoever organ that the TB has affected. So you need to have good and adequate nutrition. Our people are poor. Now, if you say you need to have the risk factor for this TB itself is malnutrition. So this person that is in itself in ab initio malnourished, and that's why he's coming down with TB. You are not subjecting him to medications that will need nutrition to make these drugs work properly in his system. So you can just imagine the cascade of problems associated with this TB management. We've talked about transportation from where these people are to seek treatment of TB. Good enough, a good system is available in the FCT, where you have good structure and a good, as well as a robust system of reach out to even these patients. But how many of these systems are available in states? How many systems or such systems are available in local governments? Because these are where these patients reside. How are we able to take this treatment to the doorsteps of these patients? Because at the end of the day, it is about bringing the global burden down. And if we are unable to do that in all these places, it means we are still in trouble. Now, the treatment of TB in itself, currently through the Nigeria Association of Resident Doctors Research and Statistics Committees, undergoing a lot of research on some of these neglected diseases. We are found in all states of the Federation. I can say we are found in every secondary and tertiary health system in Nigeria. And we have this reach out. Through the doctors reach out program, which we do to IDP camps and to vulnerable groups in the country, we realize that a lot of this information is underreported. And that was why we had to take up the challenge of making research in this to bring out figures that will tell us where we are currently. Because it's not enough for us to have figures that is reflective of what we see in tertiary health system as well as the secondary. What do we have with regards to figures and numbers in the IDP camps? We have a lot of IDP camps in this country that even have zero or very minimal access to figures that are reported that gives this picture of what we have. Now, if these people today have access to foreign donor agencies that are able to make these drugs available, or that are able to make these investigations available, how is this system being able to be transmitted down and coordinated in such a way that every vulnerable group have access? Every vulnerable group has not just access, but benefit maximally. Because if you are now giving drugs and you are giving investigation, what are we doing with the social demography of these patients? What are we doing to making sure that these things are sustained? Because one of the problems we have with TB is this multi-drug resistance that we have. And key in this is lack of compliance. You see people having a lot of psychological effect from even stigma. People are discriminated against because they have TB. People don't want to associate with you because you have TB. And you know, this go a long way in even giving you depression as a patient. We usually want to look at the holistic approach in the management of these patients. And sincerely, in as much as we must commend government in what they are doing in the big centers, we also have to do a lot going down the lane, going down to places where we don't even have access, complete access. There are places in this country that don't even have access to what we are talking about now. What do we do to those group of people? So for us as doctors, we feel we have this responsibility. And that is why we are coming to the studio to buttress this fact, to raise this awareness. Good enough, NTA has given us this platform, and NTA is doing a lot in disseminating this information down, because it's only NTA that I will say in quote that the poor man will have access to in the comfort of his room, as well as having access to viewing it from every local government. So I think a lot needs to be done, not just in the provision of drugs, medication, and the conventional treatments, but the non-conventional aspect as well. Thank you.
Dr. Kefas James, thank you very much for your contribution. And Nigeria on the network service of the NTA. And we've been discussing how to end tuberculosis by 2030. Let me get to Dr. Adewale, who is right here in the studio. I'm just looking at the trouble that people need to go through to treat tuberculosis. Is it possible that after being conclusively treated, that you can, get tuberculosis again and be treated again, or you earn immunity by just being conclusively and properly treated?
All right, thank you very much for that question. Like, I'll relate it to malaria. People come down with malaria. When you treat them with anti-malaria, they come back again with malaria anytime they are being bitten by the mosquito. So same to TB. If you treat a TB patient, like we have said, the treatment between 4 to 6 months for the drug susceptible TB. So different from the drug resistant TB. Though with the paradigm shift now, drug resistant TB is also 6 months treatment, depending on the area of the body. Sometimes it can be as long as 9 months. So, sorry that I will digress a bit. The treatment of TB in which injectables are used were the second line. That is for the drug resistant TB. It used to be. But now with the paradigm shift, we have all oral medication. Just 4 medications, for the treatment of TB. That is for the, paradigm shift in the treatment of drug resistant TB. Back to the question, treatment of TB, like every other, if you're, what we do in our own center in FCT, we concentrate more on adherence counseling. Because if the patient is diagnosed of TB, confirmed of TB, you discuss with the patient, what are the chances? What are the complications if you don't take this medication? So we discuss with them. We ensure that the patients are on the same page with us before we even commence them on the medication. Because this is the medication you're going to be taking for a period of 6 months. That is the idea of DOT. The idea of DOT is directly observed therapy or treatment shortcut. Because of the drug burden, again, let me bring it out here. Because before, it used to be 4 drugs, sometimes 5 drugs. So, because of the drug burden, it has been really reduced. Now, all those 4 drugs, they are combined in one capsule, depending on the weight of the patient. So, by the time we look at your weight, we want to know if you're going to be taking one tablet or yes, depending on the weight. But by giving the patient all they need to know about taking this drug, within 6 months, you are okay, and you can be declared cured of the disease if you take it.
You cannot come down with it again?
No, you can come down with it because
just like
now it's part of the adherence counseling we give to them. Because again, when somebody comes with TB, you of course know this person picked this TB from, somewhere. So as a medical doctor, when you take your history, so you want to know some of the history, where the person lives, what kind of work does the person do, because there are some works too that can predispose you to TB. So by the time, there's something we call contact tracing. So where this person comes from, you have to look for a way to get some of those close relatives that they stay together. So possibly screen them or possibly do TB tests for them. So by the time you do that, some of them, you may be surprised that even the person that is coming, the index case you're seeing is not even the primary case of the TB. So that's what we do to get them early treatment, early diagnosis and prompt treatment. By the time you go back to the community, those around them that are very close, that are the close relative, you place them on what is called TB preventive therapy so that those people don't come down with the TB. And then by the time you start the patient on the medication, it will be of note to you that in the first 2-3 weeks of taking that medication, even the patient will come and tell you that, doctor, I feel better, this cough don't they go. All those drenching eyes, sweat, low-grade fever, they will tell you car is improving. Most of them, they actually do well. A lot of them respond very well. But the problem is, some of those patients that are very stubborn, by the time they start responding, they will say, I don't need.
Okay, there's no need to continue.
They may not want to. So the idea of DOT, like somebody mentioned earlier, that is they will be coming every day for the drugs. No, that's the idea of that, but in the real sense, it's not done like that. There are two phases of treatment of TB. That is the drug-susceptible TB now. The intensive phase, the first 2 months, where you take all the 4 drugs combined together. While the continuation phase, the last 4 months, you take just 2 of those drugs combined together in 1 tablet. So, you know, in the intensive phase of treatment, where these patients are taking, you know, this medication, you advise them, you give them, you know, because you are going to take this drug, the fact that you are taking the drug, if you take it the way you are supposed to take it, you get better. But if you don't take it very well, sorry, let me just quickly, because now in that intensive phase, they come every 2 weeks to get their medication. So why in the continuation phase, they come every 4 weeks for their medication. And there are some tests too we run for follow-up at 2 months, 5 months, 6 months to check, you know, the level of TB bacilli in the sputum.
All right, beautiful. So I like that explanation. I mean, so it's not like an everyday thing since it's the 6 months treatment. Dr. Ekele, of course, we can save ourselves all this headache if we stay away from TB. How can we prevent it?
Well, thank you for that question. You know, to prevent TB, in fact, the best way for us as a country to prevent TB is to get everyone who has tuberculosis treated. You know, just like you said, there are some professions that predispose you. For instance, you're a bus driver, this bus has AC, so all the windows are going to be closed. Maybe you're a long-distance driver. You know, you're taking passengers to a far place. You are going to be together at that bus for 8 hours. Of course, you don't know who has tuberculosis, you know. So maybe the person might be in the bus coughing, and all of you are at risk of getting the disease. So the best way to prevent the tuberculosis is what we've been talking about, you know, getting the awareness down to the grassroots so that we treat everyone who has tuberculosis. Just like my colleague said earlier, if like in the IDP camp, one person comes out with tuberculosis, then every other person is at risk. You know, since we know it's a communicable disease, you know. So the best way to prevent it is to make sure that those who have tuberculosis are treated, you know, and to, you know, we as medical professionals to encourage them, because it's not easy, you know, the pill burden and all that, coming to get the medications to complete their treatment so that they are cured. You know, they don't develop resistance, because just like we said, that you've been treated doesn't mean you can't.
So ending
have it
TB
again
is the best way to prevent TB generally.
Yes,
Is it true that those who, about 50% of those who come down with TB have other illnesses, or other illnesses are the triggers for TB?
Well, I don't know about the percentage, but just like you said, being immunosuppressed, for instance, like HIV, those who have HIV, they are also at risk of developing tuberculosis, or those who have any other immunosuppressive disease like diabetes, you know, they are at risk. It's not to say that those who don't have those diseases cannot also come down with tuberculosis. So if you're immunosuppressed, like you have HIV, you're at risk also of having tuberculosis, like we said, HIV and TB, like a brother and sister, you know. Or if you have,
and then you mentioned diabetes.
Yeah, even diabetes, you know, it's kind of immunosuppressive too, so you can develop diabetes. Apart from that, if you're also on other drugs that can suppress your immunity, like the steroids, you know, some people go ahead and place themselves on that self-prescription. They take prednisolone, that's the very popular steroid, for a long time. I've heard a patient say that he was taking it to improve his appetite, and then in the end he came down with tuberculosis. So if you're also on other medications that can suppress your immunity, you can come down with tuberculosis. But that doesn't mean if you don't have any of these conditions, you cannot also go down with tuberculosis. So to prevent it, mainly we have to do all these things that we have highlighted, you know, training people to go down to the grassroots. We as medical practitioners, you know, increasing the awareness, and then the government on their own part, providing the drugs, you know, just like my president said, what if Global Fund is not there? What do we do? Providing the drugs. And then maybe we can even make it easier for the patients, you know, the part that they have to do on their own, you know, the folders, other investigations like the liver function test and all that, those ones they have to pay for. Maybe if we make the program more robust to be able to pay for all these other investigations for them, maybe to make it easier for them to really access the treatment and stay in the treatment till the end. That will really help.
Okay, thank you very much, Dr. Ekele. We'll head back to Jos, but we'll now be on the fast lane because we're running out of time pretty fast here. So let me get to Dr. Susan again in Jos and say, look, Nigeria is dealing with lack of facilities. At least most of us tend to have agreed with this. Is it very necessary at this point, or how necessary would it be to allocate more funds, you know, through the national budget for TB particularly?
Thank you for the question. This is very important. Forget the fact that we've said that tuberculosis is the disease of the poor. You will find yourself as a rich man one day entering the bus, or you find yourself one day caring for your relative that doesn't really have, that is sick. So in one way or the other, even the rich is also affected in one way or the other. So helping to strengthen our healthcare system at the federal government level is key and important for us. So let's take an example. If we have good primary healthcare centers, properly trained healthcare workers, both the doctors, the nurses, and the ad hoc staffs, and then coming down to the secondary healthcare center where you have trained doctors, trained nurses, and advocate staff, and then they have this gene expert machine accessible to all of them. It helps the patients to access care easily, and also help the patients to be diagnosed correctly, and also get, if we get the DOT units to such facilities, the primary healthcare center and also the secondary healthcare center, then it makes life easy even for the people, and then only complications will be left for the tertiary health care center. So it's very important for our government. If I read this morning that about 13 billion US dollars is advocated by the UN for the treatment of tuberculosis worldwide. So if we're able to get part of this money, and then this money is via the Federal Ministry of Health and also the State Ministry of Health, and via the agencies for TB and Leprosy Control Center, if these monies come along and these agencies, these healthcare are strengthened and are developed, and healthcare workers are being trained properly, then it will go a long way in ending tuberculosis by the year 2020. Then also not just building more primary healthcare facilities. First of all, if you find people on the street, how many of them know about the symptoms of TB? Just few will know. So it's very important that if these monies come along and these agencies are built and people are trained, more people will get to know about tuberculosis. More people will get to know that these symptoms are chronic cough greater than 2 weeks, associated with drenching night sweat, with low-grade fever, and then significant weight loss despite good appetite, right? So once you see someone having
very much, Dr. Susan, for the rest of the
care in the next primary health.
Some of the symptoms of tuberculosis, and of course subnationals we need to do much more. We'd like this number to scroll just so that people can take it down. If you want to get information concerning TB, you can call 3340 or dial *3340# to get more details, just in case there are things that we have not mentioned. And just so before we wrap up, Dr. Kevin, just in a few seconds, I want you to tell us what the target is in Nigeria, because I understand that WHO has set some targets, reducing incidents by 50%, reducing death rate, and all of that. What is the target for Nigeria as we look forward to 2030?
Well, I think in September 2023, at the UN House, virtually all the heads of nations agreed. You know, there was this thunderous agreement that everybody should key into the target of the UN. That's by 2030, that tuberculosis should be addressed to a very minimal level. So I don't expect Nigeria to do anything different. Okay, so Nigeria just needs to key into those target figures that has been set by UN. And if we can, which of course we can, I believe in Nigeria, we can even go beyond what is expected of us to do. So ending tuberculosis in 2030 is doable. It's doable. I think we can do it with everyone, including with what you people are already doing on the national television, you know. creating this awareness. And if we can still go further, doing some of the jingles like you mentioned earlier, maybe in collaboration with the with our association, I think we'll achieve that target.
All right, thank you. So, Dr. James, we'd like you to hear your final thoughts as we wrap up this conversation. By the way, star 3340 is toll-free, so you could actually text or you could call that number. Dr. James, your last words as we wrap up.
Thank you very much. I want to say that ending tuberculosis is everybody's business. It's not just restricted to the healthcare workers, it's not just restricted to government, but it is a responsibility that both the rich, the poor, those within the hospital setting, and those outside have to come together. Let's join hands together to fight this menace and bring it to a conclusion. Thank you.
James, the chairman, NAD Medical Education Committee, thank you for your insight on the conversation. Of course, we do appreciate Dr. Kwashak Kevin, President, Association of Resident Doctors, Youth, and Senior Registrar, Urology, Global, and also a Global Health Expert. Many thanks for joining us. And of course, we appreciate Dr. Jakim Garos Susan, Senior Registrar, Infectious Disease, Youth. Many thanks, doctors, for joining us in our JOS studio. We do appreciate you sincerely. Of course, right here in the studio, we want to also appreciate Dr. Adewale Samuel Adeleye Premier, Senior Registrar, Community Medicine and Public Health, University of Abuja Teaching Hospital, Gwagwalada. Thank you so much for joining us for the conversation. Also an Assistant Secretary of the NMA FCT chapter. And of course, thank you so much for joining us for the conversation. Dr. Ekele Amadi Robert, Senior Registrar, Pulmonology, National Hospital, Abuja. It's been a very educative program, and I'm sure that, you know, a lot of people have been enlightened. Like you said, awareness is key to ending tuberculosis. So that's our program this Friday. I'm Ian Ray John. Enjoy your weekend.
All right, and I'm Victor Azu. I also want to join the doctors as you commemorate the World TB Day on Sunday. That yes, we can end TB. That's in line with the theme for this year. Thank you very much for watching, and see you on Monday.